Today we're going to be with Dr. Bernstein, and we're going to make a video on some very common myths in the treatment of type 1 diabetes, not just for adults, but children in particular. And before we get started with the myths, I'd like you to introduce yourself, Dr. Bernstein, talk about who you are and what your approach is.
I'm Dr. Richard Bernstein. I guess my main claim to prominence is having had diabetes, type 1 diabetes, for about 70 years. I'm 82 years old, and I invented blood sugar self-monitoring back around 1969, and basal bolus insulin dosing about 2 years later, maybe a year later, and I've been looked upon as the enemy of organized diabetes medicine because I advocate normal blood sugars for diabetics. I maintain that diabetics are entitled to the same blood sugars as non-diabetics. That's how I managed to stay alive this long, and other people can do the same thing.
Okay, I'll quickly introduce myself. I'm Richard Dikeman, and I'm the producer of Diabetes University. My son's a type 1 diabetic and follows Dr. Bernstein's prescriptions with great success. So let's talk about some of the myths of diabetes. I have 7 of them written down. And the first one I want to talk about is something I see all the time in social media, and that is myths on ketones. So 3 simple questions. When should I test for ketones? When should I worry about ketones? And what should I do about ketones? And the reason I'm asking is that you see time and time again that doctors will see a kid with very high blood sugars, and they will ask the kid to test for ketones. The kid sees ketones, and then the doctor will give the kid a lot of carbohydrate and a lot of insulin to try to flush the ketones. Can you talk about that strategy? And
it's not a strategy that I would pursue. Ketones per se are not harmful. What's harmful is the complex of dehydrating events that go along with ketoacidosis. Usually these kids are vomiting or have diarrhea or have both vomiting and diarrhea, have very high blood sugars, and therefore are peeing away glucose in their urine and peeing away a lot of water. Plus they have ketones and they're peeing away the ketones. So they're losing fluid from a number of orifices, and that dehydration can kill them. And it can kill them rapidly. So they need 2 things. They need normal blood sugars and they need rehydration. And aside from my patients, who rarely have such high blood sugars but sometimes get sick and are vomiting and so on, most patients need to go to the hospital for intravenous saline, plus insulin to get their blood sugars down. And getting the blood sugars down will also get rid of the ketones, but the ketones are not the main culprit. The main culprit is dehydration. Now, I train my patients. Every new patient gets about a day and a half of training. And we go through dehydrating illnesses. And I tell them that when you have a dehydrating illness, whenever you pee, test your urine for ketones if you're in touch with me. This is not for any medical reason, but because if something happens to you and I did not instruct you to test for ketones, I'm violating the guidelines of the American Diabetes Association, and I could be held liable because I'm not adhering to guidelines. Learning about the amount of ketones is not going to change my mode of treatment, which is going to be to keep your blood sugars normal and keep you rehydrated. By the way, if you're at home, we have means described in my book, Diabetes Solution for Rehydrating. And the easiest means, by the way, is something called sugar-free power shot, which is a mixture of electrolytes without any carbohydrate that are a source of water, sodium, chloride, potassium, which together would be sort of equivalent to what they should be giving you in a hospital. So, and we also use substances to stop the vomiting and stop the diarrhea. So it's a matter of rapidly stopping the loss of fluids, not pretending that this isn't going on and looking at something else, namely the ketones.
So comment on the strategy that we always hear where doctors give carbohydrate like a sugar water, like a Gatorade, or give a glucose IV, not a saline IV, and then give lots of insulin to deal with to flush the ketones.
All I can say is that this is harmful. The ketones aren't the culprit. The dehydration is the culprit. If you're going to give glucose and raise the blood sugar, even though you're going to give insulin, there's a time delay between the glucose and the insulin. Plus, most doctors don't know how much insulin to give for a certain amount of glucose, and therefore you're getting the blood sugar even higher and causing more dehydration.
So the glucose...
And it's the dehydration, severe dehydration, that is dangerous to the brain.
So you have some kid coming into an ER and a doctor is going to give them glucose IV. If they're coming into the ER, if they're in DKA or dehydrated and near DKA, what can happen?
Interestingly enough, if you get dehydrated enough, the brain can actually swell. These kids frequently die of cerebral edema, and it's from the dehydration. You don't find ketone poisoning in the brain. The brain can live off of ketones when it's not getting adequate glucose, because you need insulin to get glucose into cells. It can live off of ketones. So doctors are looking in the wrong direction. They're not adequately addressing the dehydration and high blood sugar.
Glucose.
And they're looking at a fantasy.
Glucose.
Yeah, the ketones are there, and they're a sign of very high blood sugar, but we now have blood sugar meters, and we know right away what the blood sugar is. Mm-hmm. When I was a kid, if you had 4+ glucose in the urine, we knew that could be because your blood sugar is high now, or was high 3 hours ago, but now is normal. So you didn't know anything about what your real blood sugar was. So they'd have you test your urine for ketones at the same time. And if your ketones were high, very high, at the same time that your glucose was very high, you are to assume that your blood sugar is probably very high and you should inject some fast-acting insulin and drink a lot of fluid. That was before we had blood sugar monitoring. Now we can measure blood sugar. We don't have to use ketones as a guide to high blood sugar.
I have seen a plot that shows the probability of DKA versus HbA1c that was gathered from a large database, and it shows that the probability of DKA goes virtually to zero when normal blood sugars are attained by the diabetic, and it goes up in a linear fashion basically as A1C increases. Why is that?
As A1C increases, you're encountering people who are following standard guidelines, eating more and more carbohydrate, taking large doses of insulin, which are unpredictable in their effect, and getting unpredictable blood sugars. Whereas the people who are on low carbohydrate diets and getting small doses of insulin, we're talking, remember, about type 1s only, don't have wild fluctuations. So the more carbohydrate, the more insulin, the wilder the fluctuations, the more likely you're going to go off at the high end with ketoacidosis. That's how simple it is. It seems sort of obvious, but I guess one could say doctors can be simple-minded and not see the whole picture.
Okay, let's move on to our next myth. I want to talk about the myth of brain development. We hear another comment we hear a lot in social media is that children need 130 grams. There's a magic number that's been invented as if we evolved eating 130 grams of sugar every day for brain development. Now, when I fed my kid 130 grams of carbo every day, his blood sugars were all over the place. And I can't understand how that could be good for brain development. But where did this myth come from? And is it a myth?
It's an absolute myth. The rapid-acting carbohydrate that's advocated by the American Diabetes Association and other professional organizations, which is the source of the concentrated carbohydrate that enables you to get the carbo up so high, is unnatural. Humanity did not evolve with bread. We evolved mostly as carnivores. In fact, we still have canine teeth for that reason. And artificially loading people with carbohydrate, which is alien to the evolution of humanity, is not going to be good for the brain. Humanity evolved and the brain evolved without rapid-acting or concentrated carbohydrates or sources of readily available carbohydrate. Now, what we see in the scientific literature is that children with elevated blood sugars, which is virtually all type 1s, do not attain the IQs that they would have achieved if they did not have the high blood sugars that they're experiencing. There are one report will use MRI studies, another will use PET scans, another will use another form of imaging, and they all show different regions of the brain that are adversely affected. There are studies that involve psychological testing. There are studies that involve IQ testing. The number of studies are becoming overwhelming to show the damage to the brain in children from the high blood sugars. Yet, look for any studies attempting to normalize blood sugar in the scientific literature. You'll see virtually no successful studies.
So tell me about the biochemistry of the brain. Does the brain even know how much carbohydrate you're eating, or does it just know your blood sugar?
Well, it's too complicated a question, but it suggests to me that I jump to a related subject. Why is it that so many people, including many doctors, crave carbohydrates? Carbohydrate, in fact, has repeatedly been said to be an addicting substance. Not necessarily a good substance, but addicting. Carbohydrate stimulates the production of insulin. Insulin stimulates the building of protein and the converting of amino acids in the blood into protein molecules. Protein molecules compete with one another for transport into the brain. The brain needs a number of substances, including proteins. And there's a transporter called LNAA. It means low molecular weight neutral amino acid transporter. And it transports certain amino acids, including tryptophan, into the brain. Now, competing with the tryptophan are all these proteins that would otherwise go into muscles if your insulin levels were high. So if you're eating a lot of carbohydrate, insulin causes the other amino acids to go into muscle, giving tryptophan a free ride into the brain on LNAA. And what is tryptophan? The precursor of serotonin. It's like increasing the levels of Prozac in your brain. It calms you down. It relaxes you, makes you feel better, antidepressant. So by eating a lot of carbohydrate, you feel relaxed. And many people use carbohydrate as an antidepressant. The classic story is the lady whose boyfriend dumped her, and she goes out and eats a quart of ice cream. So we can see an interesting effect indirectly of carbohydrate on the brain. It causes the body to make more insulin if you're not diabetic, and that increases your serotonin levels. That's one of the many mechanisms by which a craving for carbohydrate exists once you're exposed to it.
So in conclusion, what about this 130 gram myth for brain development, and what is your recommendation?
I have no idea where that why that recommendation came about. My recollection is that the American Diabetes, somewhere along the line, came up with a recommendation for 137 grams. They had no evidence for it, but much of what they say is not based on evidence. I don't know where it came from. It certainly is not realistic. As long ago as 1980, Bill Tamberlane at Yale showed that when you look at a diabetic child, initially, upon diagnosis, they fall off their growth curve. And they stay off their growth curve until you normalize their blood sugar, which he was aggressively able to do using blood sugar self-monitoring in the days when the ADA objected to it. And when you normalize their blood sugars, they go back on the growth curve. So the game plan is to normalize blood sugars, not to give them more carbohydrate. And these kids who are getting more and more carbohydrate are falling more and more off the growth curve. So it's not only their brains that are not growing adequately, but their bodies are not growing adequately.
So in place of the carbohydrate, you recommend for the kids to eat?
I recommend that we go back to the sort of food that our ancestors ate, namely protein, and that we take some low-carb vegetables to get phytochemicals that may have been available to our ancestors.
That covered my other myth, which was the myth of growth. But here's another one. I hear a lot that that low carb is a lot of work, and that seems to be a myth to me. Now, diabetes is some work, particularly for parents because you have kids with a lot of growth hormones. So I don't want to minimize the amount of work that I do. My kids my kids' blood sugars are normalized, but I work at it. I get up at night. But what is your explanation for the amount of work it takes to be a low carber versus high carber? Do you think it's the same amount of work or less? I think it's a myth that there's more work to be low carb.
Well, I sort of disagree with you, but for a more obscure reason. The people who are going low carb are trying to get normal blood sugars, and they're doing more things than just the low carb. They're measuring their blood sugars, they're taking small doses of insulin, whereas the people who are following the professional guidelines are paying less attention to their diabetes. Right. They know that on the diets they're following, they cannot achieve anywhere near normal blood sugars, so they don't even attempt to get there.
Right.
They just ignore it. So it doesn't involve very much work. It involves a lot of hypoglycemia, usually several episodes a year of ketoacidosis, etc. The low-carb ball game is more than just low carb. It's doing whatever you have to do to keep your blood sugars normal.
Gotcha. Well, trying to normalize...
That's a lot of work.
try to normalize your blood sugars with a high-carb diet, I guess, is much harder because you would have to do even...
Well, it's impossible.
It's impossible.
It's impossible, and most people give up.
Right.
When I speak to doctors who are recommending the high carbohydrates, they likewise recommend that you not pay very much attention to your blood sugars because they know how hopeless it is. And they come up with things like, well, diabetes is enough of an emotional impact on a person. Why make him do all these things and make his life even more agonizing? And of course, the fact that going blind or losing your legs or being on dialysis is even more agonizing than that, they bypass. They don't even talk about. How many doctors go into detail telling their patients about the long-term complications of diabetes?
Well, that brings me up to my next myth. You kind of answered it, but you can go in more detail. Another catchphrase I hear in social media that's been popularized is kids first, diabetes second. And when I hear that, it's a signal to me that there's some sort of unrestrained intake of carbohydrate taking place for the kid. He might be at a birthday party and eating cupcakes and juices and things like that. I asked for two comments. One is, what is the immediate feeling like for these kids who are going to go have extreme roller coaster blood sugars, maybe up to 400 or higher, and then come crashing down? And second, what is the long-term or even the short-term impact of that style of management, kids first, diabetes second?
Well, first of all, I believe that kind of statement, if it comes from a parent, really means parents first, because the job is too difficult for the parent. I've seen all kinds of related interesting behaviors on the parts of some parents who really don't want to be deeply involved. And it's much easier for the parent to be relatively laissez-faire. But of course, they either have to keep the kids' blood sugars very high, or they're going to have a lot of unconsciousness and convulsions and whatnot. So they tend to prefer to have them very high. I remember when I was active in one organization that is very well known for raising money for supposedly finding a cure for diabetes. And it was really a way of the parents doing something without really getting involved in the treatment of their children. Where they could say they were doing something, they could be proud of what they were doing, but they weren't directly helping their children. So I think this kids first, diabetes second is bypassing the issue. Because if you ignore their diabetes, you're not doing them not doing anything beneficial for them.
Well, a lot of these kids are too young to signal what does it feel like. As a parent, I have no idea what it feels like to run a blood sugar of 300 or 40. You're a type 1 diabetic. What does it feel like?
I know that if I get to 120, I feel sort of wiped out, thirsty. I'll be drinking continually. Now, why is that? It's because I'm used to normal blood sugars, and it's so alien to have these high blood sugars. My metabolism is screwed up. In the old days, before I had a blood sugar meter and before I had figured out what to do, I used to come home at night and my wife would say, "How you feeling?" And I'd say, "All washed out." And she'd say, when she looks back in those days, she says, "And you looked all washed out." I was always exhausted and feeling sickly. And you're making these kids feel sick. They don't even know what it feels like to have normal blood sugars, many of them. And when I treat patients, frequently within a matter of days, like 2 days, they say, "I haven't felt this good since before I became diabetic." There is a difference in how you feel, and it's a tremendous difference. And this is being ignored.
Isn't it possible that in a few years there'll be a cure, or there'll be an artificial, or what I call the automated pump, and let the kid have a cupcake and enjoy himself at the birthday parties or the holidays? Or what's the downside of that approach? I mean, you just kind of answered it, but
well, first of all, if you're dealing with things like mechanical devices, they cannot operate fast enough. The drugs we have, like injected insulin and so on, don't work fast enough to cover the effects of rapid-acting carbohydrate. And the kids will feel sickly later on. And yeah, eventually you get their blood sugars down. And you'll still have the roller coaster until you actually reverse the diabetes, which requires more than mechanical devices.
how about long-term effects? Isn't it going to be so far in the future that we won't see any, by the time there's a cure, we won't see any complications?
Well, you mean the opposite, that by the time there's a cure, a new diabetic today will have a whole list of complications. Mm-hmm. And yeah, the cure probably is 12 to 20 years down the road. We're getting closer and closer. And I've seen people who were diagnosed 5 years ago who have a load of complications and didn't even realize it. I saw a lady just last week who had relatively mild diabetes, not a type 1, and she had what's called sympathetic neuropathy in her lower extremities, which meant her feet could not sweat. And although she only thought she had diabetes for maybe 2 years, her feet were scaly and dry. That's not natural. That happened fairly rapidly. And there are myriads of other complications that they get that they don't even know they have, even after a relatively short period of time.
What kind of A1Cs are you going to get down to avoid that? Because that's another myth. The guidelines say 7% or something like that.
Well, 7% is an average blood sugar of 180, and according to a number of studies of entire populations, normal blood sugar is around 83. So you're talking about almost 2.5 times normal, and that's pretty darn high. And boy, if I were 50% above normal, I'd feel pretty sick. So these A1Cs pushed by the professional societies are not beneficial to the patients. They protect the doctors from getting sued over hypoglycemia.
Okay, here's our next myth. The next, this is another comment I see a lot in social media. It has to do with eating disorders and depression. And the thinking is that if I remove sweet foods or wheats or fast-acting carbohydrates, in any way restrict my child's diet, or if my child wants to restrict their own diet, I'm going to somehow cause an eating disorder on the child or cause them to be depressed. What do you think about that?
I think that again, sounds like it was created by a parent or a doctor who's trying to avoid something, using the child as an excuse. It's very common to put the blame on the patient. Very common thing in medicine, put the blame on the patient, not on the treatment. I've treated a lot of patients, and the kids, for the most part, want their blood sugars to be normal, as best as they could. And they know that if their friends try to coax them into eating carbohydrate, that they're going to send their blood sugars up. And the big problem can be with friends. I've seen two groups of friends. One group are very interested in the patient's, in the kid's blood sugars, and they ask him what his blood sugar is when he tests, and they try to accommodate him by not eating candy or whatever in his presence. And then there's the other group that tries to get him to eat the stuff that they're eating. And this does make it hard for the patient. And does it make him depressed? I don't know that it makes him depressed or causes an eating disorder, but it certainly makes life harder if the friends are not helpful in that regard.
Any tips for that situation?
Probably to get the friends over and have the parents give a rational explanation to them of what's going on, and could also explain that this is the same sort of thing that makes kids fat and could make the non-diabetic kids potentially become diabetic, especially if they have it in their families. So trying to get cooperation from the friends has been helpful. I've seen it. Now, there are diabetics with eating disorders, and is it higher amongst diabetics? I've seen articles claiming that it was higher amongst diabetic girls, it's usually related to fear of obesity. And I do know that in anorexic patients, non-diabetics, that the undereating is frequently related to over-control by the mother, where the mother tries to dictate everything the child does, and one thing the mother can't control, at least when she's not around, is what the child eats or doesn't eat. It's not a matter of taking away carbohydrate. You'll find that in none of these studies of eating disorders in diabetic kids was there imposition of carbohydrate restriction. It's just not done out there in the professional diabetes community. Mm-hmm. That is, amongst the people they study or the people they treat. They're, for the most part, not restricting carbohydrate. Very few of the doctors are doing that, which is sad.
What about haven't you done a study on depression? Slightly different, obviously, than eating disorders.
Yeah, but we did a study on depression many years ago. Before I became a physician, I had the mythical assumption that when I introduced blood sugar self-monitoring, doctors would jump for this as a new mousetrap, so to speak, that every patient should have. I didn't expect that the American Diabetes Association would fight it tooth and nail for 10 years. I didn't expect that the president of the ADA, who was my physician, would say to me, when I asked him, what about your other patients? He said, you're telling me I should lose all my patients. They come to me once a month for a blood sugar. If they could measure it themselves, I wouldn't have any patients. So running into this, I said, I've got to show that you can reverse complications with normal blood sugars. I had read articles of this happening in rodents, in particular kidney disease, but I had seen my own complications reverse, and I wanted to demonstrate this. So it happened that Rockefeller University, in those days it was Rockefeller Institute, was doing studies on hemoglobin A1C. I said, this is a great place to test what I'm doing. And I got them to recruit the worst patients from the diabetologist population in New York City, the patients that diabetologists wanted to get rid of. And we actually got two groups, one at Rockefeller, one at Downstate in Brooklyn. The Rockefeller group, I think, was 12 patients, and Downstate, I think, was 16 patients, or it may have been the reverse. In any event, because the doctors who had given us their patients said, but you're going to make them crazy, you're going to make them depressed if they do what you're doing. That's what I was doing for myself. Mm-hmm. And I brought in, at Rockefeller, a psychiatrist who happened to be a type 2 diabetic himself, and a psychologist at Brooklyn. And they both administered, before we even got started, the Hamilton Depression Scale, which is a study for depression. And in both groups, we found that the average score was severely depressed. It was up around 20 in both groups. And what we found was that once they learned how to control their blood sugars and keep them normal, they went, I believe, under 6, which was no sign of depression. There was one exception. It was a girl who had bulimia in the Rockefeller group, who never stuck with the program, we couldn't get anywhere in controlling her blood sugars, and she remained up there in the 20s, but everyone else came down under 6. So here we actually reversed depression by putting the patient in control. And I interviewed the patients afterward and actually quoted them in my first book. They, many of them wrote little stories about themselves. And essentially, what they all said was, I was walking a tightrope in the past. My blood sugars could be either very high or very low. I was always in danger of severe hypoglycemia. Now, my blood sugars are whatever I want them to be. I'm in control. I'm the captain of the ship. Mm-hmm. So we reversed depression and anxiety. And it was very simple and easy to demonstrate. What's interesting is no one has repeated those studies, attempted to normalize blood sugars.
Right. Haven't seen anything like that either.
And it's in part due to the almost violent opposition by the professional associations.
And yet we saw the other day a paper that came out that shows that in the last decade, kidney disease in pediatric patients has tripled. So all this new technology doesn't seem to be doing any good.
Because they're also getting more carbohydrate.
That's right. Okay.
And I might add that probably one of the reasons for professionals being so opposed to blood sugar, to normal blood sugars, is that they're never taught how to do it. They don't know how to do it.
Right.
The only ones who know how to do it are the type 1 doctors who have read my book.
Right. Exactly.
And they're using it on themselves and to some extent on their patients. But what I get from them in the way of feedback is that they don't have the time to teach all this to their patients. They can't afford to spend the time with their patients that it takes to teach them how to do it, what the book tells them.
Yeah. It's sort of anecdotal, but in my experience, there seems to be 2 doctors when presented with a patient who's read your book and normalized their blood sugars, and the majority of the doctors seem to become angry and really cling to the myths. But the other type, they kind of have an aha moment and say that they always suspected it was the carbo load that was causing these blood sugar issues, and to stay the course. So.
Right, but remember, it's more than cutting the carbo. You have to do a lot of things like checking blood sugars and intervening.
Yeah. Okay.
And your hundreds, if not thousands, of kids that visit your site are doing just that. They're doing a lot of things.
Yeah.
And it's working.
We have 2 myths left. One myth is that another social media comment. I have a very active child, and he's doing a lot of sports, so I can't cut his carbohydrates. What is it about? What is carbohydrate? Why would you? What is the myth that you would need that for athletic performance? I think most parents don't even really know what carbohydrate really is. At a biochemical level.
Well, I question when you say that you can't cut your kids' carbohydrate. You can't eliminate the use of carbohydrate for treating low blood sugars potentially caused by the sports. And I have the same problem. I go to the gym twice a week. I spend about 3 hours at the gym. I'd spend less, except I'm doing a lot of blood sugars when I'm there. And I do about 15 different exercises each time I go. And Each exercise, on average, lowers my blood sugar by about 5. But some exercises may lower it 15, some may have no effect. It may average about 5. So, and when I go down, I take liquid glucose. I carry these with me, and I try, although my usual target is 83, I'll try to get my blood sugar up to 90, 95, because I know it's going to shortly come down. And I keep on top of it quite aggressively. And I might use, in one session, 2 of these bottles. Each bottle in toto will raise me by 105. So I'm in effect taking enough glucose, and it's 30 grams here. There's more glucose, there's more carbohydrate in these 2 bottles than I have in a whole day of meals.
This is a pretty rigorous workout.
Yeah.
Okay, what about instead of that, why not just eat a big meal of pasta and carb load so that you don't, deplete your glycogen reservoirs?
Because it becomes unpredictable. First of all, 30 grams of carbo in pasta is probably only going to be 1 slice. It's not going to be, if you're talking about pizza, it's not going to be a lot of pizza. You cannot, there's a limit. You cannot build up glycogen stores indefinitely. An adult human weighing 150 pounds may have throughout her body a total of 300 grams of glycogen. That's 1,500 calories worth. That's in her entire body, and that's an adult. So if she eats more carbohydrate, she's not going to make more glycogen. There's no place to put it. So there's a myth about building up glycogen stores. Most people who have normal blood sugars have their maximum glycogen stores on board. That's what it takes to store glycogen. Not eating a lot of carb and raising blood sugar. So you go in with a normal blood sugar, and you're going to have to be supplementing with glucose as needed. Now, that leads to a story I've told over and over on interviews like this, and that is the story of the wall. Back 25 years ago, maybe 30, marathon runners would run into the wall where they'd pass out. They'd run, I think it was 26 miles on average, and they'd pass out. They couldn't run further than that. And it was discovered after years of wondering that they were experiencing severe hypoglycemia with loss of consciousness. They had used up their stored glycogen and passed out from low blood sugar. They were not replenishing their blood sugar as they ran. And what it takes is adding rapid-acting glucose while you're running. You could try adding a complex carbohydrate like bread or cookies or something like that, but that's not going to work fast enough. And then after you've stopped the running, it'll continue working for hours thereafter. So you'll be getting the bulk of the effect when you don't need it. Too late.
What about after there's a more devious question. What about after a couple of games for a kid and then replenishing glycogen stores with a big carbo meal?
Again, if you've kept blood sugars normal, the glucose that you used during the game to keep your blood sugar normal also helped restore your help maintain your glycogen levels.
Gotcha.
So I can't see, and I'm sure that if you've tried giving a big carbohydrate meal after a game, you end up shooting up in the other direction and then having to give intramuscular insulin shots and sort of dealing with a roller coaster again.
I'm a big fan of a ham and cheese omelet to replenish energy stores. So
I don't think that will do it either, but it helps. It helps build muscle, and after you do muscular exercise that breaks down the protein in the muscle to amino acids, having high protein meals helps build them up.
All right, last myth, and it's been a good hour. When you get rid of the carbo foods and you follow your prescription in your book, Diabetes Solution, you're eating a lot of protein foods. And I hear two myths on the eating protein foods. One is the myth of, now both of these you've covered in videos. One is the myth that protein affects kidneys, and the other is the myth that protein foods have a lot of saturated fat, cheese, eggs, and meats, and that saturated fat is bad for the heart. So can you give a summary? I'll link the bigger videos, but give a summary of that for people.
Well, the myth of the saturated fats was born probably as a result of a conference of cardiologists that occurred in 1958. But this was actually about 10 years after the myth started. However, this is when the major cardiologists in the USA decided that probably the cause of heart disease in this country is saturated fat, and we should eliminate virtually all saturated fat and cut way back on the total fat, I think to 10% or something like that. And this is what we recommend, but we urge that research be done to see if our guess is correct. And I sent you a copy of that article. My doctor was the moderator of this symposium. So this was a guess. And what happened was, due to a number of political issues, Senator McGovern's campaign and whatnot, the government ended up making that recommendation: avoid saturated fat. And of course, what's there to eat if you're avoiding saturated fat? There's carbohydrate. So what carbohydrate sounded good? Whole grain bread. There's going to be something magical about whole grain bread, which of course did not exist when our ancestors evolved. In any event, this turned out to be a myth. More recent studies correlate inflammatory markers with heart disease, atherosclerosis, and the likes. And there are dozens of inflammatory markers in the blood that are being looked at. The most commonly looked at one is C-reactive protein, but we have homocysteine, we have beta-2 microglobulin, we have fibrinogen, we have interleukin-6. There's a long list. And for years they were recommending statins to all Americans, all American adults anyway, because they were going to prolong longevity. They thought by lowering LDL. But statins did something else that was really important. They lower inflammation. They magically lower inflammation. And they were able to therefore show a slight increase or reduction in heart attack incidence by the fact that they lowered inflammation. And recent studies, again, every month you see more and more studies showing more inflammatory markers involved in heart disease, as opposed to less effect or no effect from things like LDL, saturated fats, and the like. There's also a basic thing that was taught in biochemistry when I was in medical school, which was Kirk in 1982. The liver is capable of making a little bit of fat, it turns out to be unsaturated fat, from dietary adipose, that's dietary fat that you eat. But the bulk of the fat in the body is made by our own adipose cells, fat cells, out of a carbon base of glucose, of carbohydrate. We make fat out of carbohydrate, and it's saturated fat. The thing is, now we're learning that the saturated fat doesn't make that much difference, but inflammation does, and that opens the door to a whole new set of drugs and new techniques of living, such as strenuous exercise and whatnot, that reduce inflammation. But it's not the saturated fats, and it's not fats.
Okay, so no worry about dietary fats and lipids and as far as heart disease.
That's right.
Yeah.
If you want to look at something in the blood, look at inflammatory markers. Those are more likely to predict heart disease.
Okay, how about kidneys and protein?
There was a myth born by, in part, by an investigator at Harvard, Barry Brenner, back around, I guess, late 70s, somewhere around 1984, where he put diabetic rats, on normal rat chow and on very high protein diets. And although all of the rats died of diabetic kidney disease, the ones on the high protein died more rapidly. And Barry Brenner went around the country, was funded to go around publicizing this, and Harvard issued press releases touting this study. What you don't hear about is Brenner went back and looked at what happened if you put these rats on a high-protein diet and gave them normal blood sugars. His first batch of rats had average blood sugars of 250, as recommended by the diabetologists in Boston. He now gave them normal blood sugars and found that there was no diabetic rat kidney disease. It vanished. They lived normal rat lives. Those on the high protein diet, those on the low protein, on the regular rat chow diet. And this was delivered at a National Kidney Foundation conference in Washington, D.C., somewhere around 1985. I happen to know about it because I had a joint paper with a group at New York Hospital that were pioneers in the study of hypertension. And we used my patients and their patients, and we published the results of atrial natriuretic factor studies. And my co-investigator, who went down to the conference, sent me a copy of Barry Brenner's report. And he was astounded that Barry would actually do this, but it got no publicity. It was published in the archives with several hundred other papers. I called the National Kidney Foundation about 5 or 10 years ago, trying to get a copy of the archives. They had moved and threw out all their back issues of the archives, so you can't find the paper.
Oh, yeah.
I don't even know if Barry Brenner is still alive and if he has copies of the paper.
I mean, let's be clear, the dialysis clinics are not filled with people on high protein diets. They're filled with people on elevated blood sugars, correct?
Correct.
Yeah. That's another myth. Well, okay, it's been a good hour. I want to thank Dr. Bernstein and strongly advocate that you get a hold of Dr. Bernstein's book, Diabetes Solution, on Amazon. That's a place you can buy it. And watch our videos on Diabetes University. You're watching one right now. There's a lot of resources out there, but those two are the top if you want to learn how to control your blood sugars and you have diabetes. Any parting words, Dr. Bernstein?
Just a reminder to take a look on YouTube or on Google for type 1 grit, where you can see the results in kids who would normally be all over the place with their blood sugars, where they show you what their blood sugars were before going on our regimen and what they are now. You'll get computer printouts from their continuous blood sugar monitors.
Yep. Over 1,000 people, the majority of which are kids, and almost instantaneously they achieve normal blood sugars. And like you said, it's not easy, but I'm including in the ease the emotional distress that I experienced when watching my son have high blood sugars. So for me, easy includes the fact that I know my kid isn't going to die in the middle of the night or come home or have a seizure in school. It's been a new lease on life as far as I'm concerned. It's turned diabetes into an absolute nightmare, into a nuisance. It's a pretty big nuisance. You have to stay on your toes, like you said, and do the work. But barring disaster, you can get used to the fact that everything's going to be okay. That's my experience.
And one more thing that I forgot to mention: normalizing blood sugar early is much more likely to preserve beta cell function and make the treatment of diabetes much easier. Mm-hmm. Kids that preserve their beta cells are much easier to treat, also adults. And that's the ball game that I play. If I try to catch patients real early so that we could preserve their beta cells and make it much easier to treat them.
Okay, thanks everyone.
Thank you for watching.